Aromatase inhibitors save lives. Hundreds of thousands of women take them every year. But there is a serious side effect that is still not being discussed enough in clinics and waiting rooms or online. These drugs can quietly devastate your bones, and the risk gets worse the longer you take them. So, what are aromatase inhibitors? Around 80% of all breast cancers are estrogen receptor positive, meaning that estrogen feeds the tumor. After surgery, most women with this type of cancer take adjuvant endocrine therapy or hormonal treatment for about 5 to 10 years to prevent the cancer from coming back. For postmenopausal women, the current gold standard is a class of drugs called aromatase inhibitors or AIs. The three most commonly prescribed are anastrozole, brand name is Arimidex, letrozole, brand name Femara, and exemestane, brand name Aromazine. They work by blocking an enzyme called aromatase, which converts androgens, the male type hormones, into estrogen in our body tissues. After menopause, the ovaries have stopped producing estrogen, but aromatase in fat tissue, in muscle, and other sites keeps making small amounts. The AIs shut this down almost completely. For cancer control, this is excellent. AIs are more effective than tamoxifen at preventing recurrence and death in postmenopausal women. Now, for bones, this near total estrogen suppression is a real problem. Remember our bone remodeling balance from episode 1, the osteoclasts, demolition versus osteoblast construction keep it kept in check by estrogen. When AI suppress estrogen to almost zero, that check is removed. The demolition crew or the osteoclasts become hyperactive. Bone resorption shoots up. The construction crew or the osteoblasts can't compensate, so the net result is accelerated bone loss. How accelerated? Women on AIs lose bone 2 to 4 times faster than the normal postmenopausal rate. And postmenopausal women are already losing bone faster than they were before menopause. The data is sobering. A meta analysis of 30 randomized controlled trials involving nearly 118,000 breast cancer patients found AI users had significantly higher rates of osteoporotic fracture. The relative risk for vertebral or spinal fractures in AI users was 1.84 compared to non AI users. That's nearly double. For hip fractures and non vertebral fractures, the risk was elevated by 18%. And if a woman takes AIs for longer than 5 years, which is increasingly more common to prevent late recurrence, the risk goes up further. Extended AI therapy beyond 5 years is associated with a 34 to 59% higher fracture risk compared to standard duration therapy. This isn't just a postmenopausal problem. Younger women with high risk estrogen receptor positive breast cancer are increasingly being treated with AIs alongside ovarian suppression therapy, drugs, or surgery that shut down the ovaries entirely. In a premenopausal woman, suppressing the ovaries and blocking aromatase means that her estrogen levels plummet to nearly zero, similar to or even lower than being in a postmenopausal state. Bone loss in this group can be dramatic and very rapid. A clinical trial of premenopausal women on ovarian suppression plus AI who were given denosumab showed significant protection compared to placebo, confirming that bone loss in this group is real, it's measurable, and it's preventable. The message is clear. Aromatase inhibitors are life-saving drugs, and the benefits almost always outweigh the risks. But the bone side effects are real, they are significant, and they increase with time. Women on AIs need their bone health actively managed, not just left to chance. In the next episode, we'll talk about what we can actually do about it. We'll talk about calcium, vitamin D, exercise, and why these three things alone are not enough. I'll see you soon.